you want me to admit people, or
all right? No, I think Aaron Aaron took care of that for us.
Perfect.
So good afternoon and good evening, everyone. Thank you for joining us for another session of Virtual Global Spine Conference. We are grateful to have you guys join us today. With us is our usual cast of excellent faculty, co-hosts, and panelists. And I'm excited to have with us today Dr. Sanjay Dhall, who is a good colleague and a friend. He's a spinal neurosurgeon at UCSF in San Francisco. Really a nationally renowned spinal cord injury scientist and surgeon. He's the director of neurotrauma at San Francisco General Hospital. And he's done a lot of research on this topic. And, you know, cervical spine trauma and spinal cord injury is just a very, very important topic. And I thought we would tackle that topic this time. So Sanjay, thank you for joining us. And we're all excited to have to go through your cases and welcome you to our program.
Ollie, thank you so much for inviting me. I'm excited to do this. I've been following your growing group or posse on Twitter. So this is fantastic, and I hope it outlives this pandemic. So I'll just start by saying the way I structured this is I was going to talk a little bit about the stuff that we're passionate here about in spine trauma and spinal cord injury, and show some cases. But I would really encourage anyone listening to feel free to interrupt me and ask questions or make comments, because that's certainly a lot more interesting than just listening to me talk. So with that, I'm going to start. So I'd like to also call out John Burke, who's our chief resident, and has really kind of turned himself into a spine trauma fellow here at UCSF, for helping me tremendously with this presentation. So there are my disclosures. They're not really relevant to this topic. You know, just, you know, a little bit about spinal cord injury and why I care so much about it. And, you know, what some of the things that we're focusing on regarding intervention, timing of intervention like surgery and other supportive care in spinal cord injury. You know, the first thing that I'll say is, you know, in spite of what at least those of us on the neurosurgery side of spine will hear from our partners and our leaders, spinal cord injury may be relatively infrequent, but it's still actually much more common than a lot of the high-profile neurosurgical diseases like glioblastoma, meningiomas that are operative, AVMs for sure, and spinal cord tumors. So and even though the epidemiology is such that it's not a huge number of patients each year, they really stack up. And, you know, at any given moment, there's 250,000 or more people living with spinal cord injury in the United States. And their healthcare costs a lot of money. You know, these studies range all the way up to $1.7 billion a year of healthcare for people living with spinal cord injury. So it's really catastrophic for a lot of reasons. One of the things that I was fortunate enough to do earlier on in my career was help write guidelines. And the first set of guidelines that I wrote was on spinal cord injury and spine trauma. And one interesting thing that I learned from that was that our literature is just not very good when it comes to spine trauma. And we were basically running off of two different categories, either case series, you know, Professor X's series of 20 jump cassettes or whatever it may be, or we had really one notable, or I guess two notable randomized control trials, which were actually so flawed that they had to just truthfully be discarded. So what I learned from that is it's really hard to do a randomized controlled trial, certainly in spine trauma. Some might even argue it's hard to do it in any kind of surgical disease because there's so much heterogeneity and so much crossover. And the SPORT trial is a great example of how these trials can fail. And so what we became really fixated here on at UCSF was a prospective data registry. And we learned from our elder siblings in the brain injury world, track TBI. And so we sought out to build a prospective data registry of spinal cord injury, and we called it track SCI. This started getting funding from
Oh, sorry, Sanjay, I think you got muted by accident. Do you mind unmuting? There you go.
Yeah, I was wondering. Okay, I thought maybe it was something I said. So, so this is now a multi-center study. We have 3 sites. And it's really focused on collecting granular data on a variety of topics in spinal cord injury. And our 3 sites currently are San Francisco General Hospital, or UCSF, and then we have another site in Fresno, which is a few hours away from San Francisco. It's about halfway between San Francisco and Los Angeles, and it's a pretty high volume trauma center. And Ohio State University. We are also in the process of onboarding some other programs that are working through that process with us now. So, I won't delve down into all the granular details of the patients that we see with spinal cord injury, but San Francisco is a really unique place to do this because our spinal cord injuries are very different. They're probably very different than what Ollie is seeing in Arizona. They're certainly different than what I was seeing at my previous job at Grady Hospital in Atlanta. They're much older patients. They're much lower energy spinal cord injuries. The majority of our spinal cord injuries now are ground level falls in elderly patients, very often at home. And so, of course, we have a lot of central cord injuries and then a lot of injuries that are through a similar mechanism, but more severe than what most people would think of as a central cord. So one of the things that we've really become focused on since I came here about 7 years ago is looking at the timing of when we do intervention in spinal cord injury. And why is that, right? So when I was in training, spinal cord injury was, interestingly, at least where I trained, essentially elective surgery for these patients. It was seen as an irreversible injury that the only purpose of surgery was really to stabilize these folks so they could go on to rehab without any real expectation of making them better. Since then, I think we've become a little bit more enlightened, and we have really started to focus on treating these like we treat a traumatic brain injury, somebody with compression of the neural elements. And this is reflected in the literature in that there's become more interest in looking at earlier and earlier surgery. What's interesting about it, though, is the definitions have evolved, right? So we, at one point, early surgery was 72 hours. Then it became
I think we may be losing your sound again, Sanjay. Sanjay, can you hear us okay?
I think it froze.
There you go. All right, good. There you go. You're back.
Ali, I think the screen has froze.
Yeah, I think Dr. Dhall's screen froze, so we'll give him a minute or two to maybe try to get that up and running again. But he was mentioning, until he gets back, so he was mentioning something that I think I know what he was heading towards, which is how we're defining kind of early surgical intervention. And this comes up a lot, right? Somebody comes in, incomplete spinal cord injury, you want to take them to the OR right away. So let me just, on his behalf, I'm going to ask some of the panelists here. So Nader, you're right here in front of me. So what in your institution constitutes early intervention? What does early intervention mean for you? For somebody who's medically fit, ready for surgery, they come in with a spinal cord injury, no major medical or trauma issues. When would you take him or her to surgery?
So, spinal cord injury in the setting of a fracture that's unstable, let's leave the, central cord syndrome and the setting of spondylosis as a separate entity, but someone with an unstable spinal fracture that has caused the spinal cord injury, and they're stable. You know, you check the ABCs and they're stable and ready to go in terms of an operation. We do them emergently. So we do them truly emergently. Like if there's a fracture dislocation, we don't really spend too much time putting a patient in traction. We just do flash traction, like over 1, 2, 3 hours max. Then we take them because, you know, evidence has shown that, you know, and we have a paper on this, even in ASIA injury, you know, the only thing that can give these patients the best chance of a neurological improvement or going from one ASIA class to another is really emergent surgery. You know, the faster you do it, the better the outcome. So within 12 hours, you know, even less, like 6 hours, whenever the patient's fit, you got to do it.
Yeah.
You know, like that's the only thing, like keeping the maps up and doing a decompression and fusion, that would give the patients the best, including ASIAs. And I've seen ASIAs going to ASIA C, D sometimes. And, you know, and there's a meta-analysis that we published that shows that looking at papers, ASIA, especially specifically ASIA patients, because these you would think that, you know, there's no chance, no hope, but still there is definitely hope in those patients too.
I think, and I agree now, I think that's where Dr. Dhall is going. So Sanjay, if you're back with us, you can share your screen again. I think Aaron will make you co-host so that that will get you to share your screen. Alex, how about you in Switzerland? What's when patients come in to the ER, incomplete spinal cord injury, what does urgent for you guys mean? Or what do you all do in terms of what's the expectation of when this patient should go to the OR?
Yeah, hello from Switzerland. Yeah, we have the same philosophy and the same principle like Nada has said. We have got 3 categories. One is immediate going into the OR. For example, a ruptured aneurysm, aortic aneurysm. This is life and death. It goes straight to the OR without any discussion. Then the second category is within 6 hours. And this is where the SCI is. The third category would be within 24 hours. So early is not 24 hours for us. Early is right from the start going to the OR or within 6 hours. It's everything is relative. But I want to point out that the unconscious patient is very difficult to treat. The unconscious patient where we think he has got an SCI, this is difficult for us. Maybe I'm not as fast as when I know it from the clinical point of view that he has got an SCI. The suspected SCI is really hard in the unconscious patient.
Yeah, no, I think those are all valid points. John, MGH, Boston, you guys obviously have a very busy trauma center, and you guys have a great trauma program, you know, including neuro, you know, basically general trauma and critical care. I know some of the guys there very well. What's the expectation at your institution, right? Incomplete spinal cord injury. Let's say they come in at 8 or 9 p.m. Do you guys take them like that night, first thing in the morning? What's early intervention for you guys? What does that look like?
Yeah, I think, Ali, that's a great question. And I think it speaks to some of the challenges too. I don't know if that's one of the things that Jay was going to talk about, but, you know, at our center, we have, you know, a neurosurgery service, an orthopedic spine service. We don't have a consolidated spine service line not many places do. I know you're trying to do that at your center now. So that being the case, we do rotate call. And even though the constant is the surgical ICU and the trauma service, as you said, we have some mutual very good friends. But the problem is that there is some variability. So I think like our bias, I think tends to be on the neuro side, that we'll take them right away, regardless of the time of day or night. But there is some variability, I just think, in the real world setting, you know, and some of that also is due to the type of staff, the type of case, the OR, you know, who's there to support that. You know, some of these can be very challenging cases. And I think that considering the resources, even at a major center, they're still limited somewhat in the evenings and, the weekends sometimes.
Yeah, good point. I see Dr. Dhall is back. Sanjay, if you can hear us okay, if you can share your screen and we'll resume your presentation. John, I think you bring up a good point, which is what also practically happens or needs to happen, say in a community setting. I think that's a valid point. Just out of curiosity, and again, I'm not suggesting this is wrong, because I think technically, maybe academically, it's not wrong, but we all have encountered situations in which we've had, partners or friends or colleagues. You guys remember when patients, these incomplete spinal cord injury patients come in, or central cord syndrome, especially in the elderly, they let them cool off, put them in a collar, go to rehab, and then come back in, say, 2 to 3 to 4 weeks. I mean, I know some people who still do that, and I think, I guess according to the older literature and according really to the old practices, that was quite common. Nader, do you still see that? Do you have colleagues? Well, I mean, not colleagues, but you that's not uncommon, right? There's still people who do that, and I don't know. What do you think about that?
I agree with that. I mean, I think the thing is, like with to me, like a central cord and the setting of spondylosis, the urgency is less compared to a patient with a spinal cord injury due to a fracture that's unstable. You can't mobilize that patient. Like spondylosis, definitely elderly. Sometimes they have medical comorbidities, and sometimes they're on aspirin. The evidence on that, it's all level 3, but it tells us that emergent surgery versus having them go to rehab, then come back and then have the operation when they plateau, there's no difference in long-term outcome. Now, still, that's level 3 evidence, but definitely surgery is better than no surgery overall. So that's what the evidence says. To me, the way, I mean, this is like different practices. The way I practice it, if it's not a traumatic disc like multi-level spondylosis and central cord with no fracture, and they say, I'll admit them to ICU, and then, I will take my time maybe, but I would operate on them during the same hospital admission. I won't discharge them to rehab, then have them come back. I would operate on them during the same. These I don't handle as urgently as a patient, or emergently as a patient with a spinal cord injury secondary to an unstable fracture.
Yeah, I think that's right. So one more question. I'll send that to Mike Galgano, and then we'll see if we can get Dr. Dhall back. That would be great. If not, we may have to go to Plan B, but then bring him back in another session. Mike Galgano, up in upstate New York. You get somebody with, say, central cord. I'm going to make it easier, not incomplete spinal. Well, it's a type of incomplete, but let's say 70-year-old male. He falls. Central cord syndrome, 9 p.m. on a Friday, otherwise healthy, no stroke, no MI, labs look good. Medicine team clears him, trauma team clears him. When would you take that patient to surgery for a decompression?
I think it depends on where they fall on the spectrum of central cord. I think we've all seen, there's some patients that come in and maybe they just have that burning dysesthesia in their hands, and in my opinion, it's not as urgent in that situation. Maybe you could wait a couple of days for them to cool off. But if they come in, they have pretty significant weakness of their hands, and sometimes they even have some lower extremity weakness too. And then they will get some spontaneous recovery. I still try to take them right away. I try to treat all these cord patients as early as possible. At upstate, for me, it's usually within about 8 hours. I'll try to take them. So if they come in on a Friday night at 9 o'clock, central cord syndrome, I'm probably taking that Saturday morning at 7:30 in the morning. I'm not sure what good it's going to do as long as they're cleared by medicine. They have no other polytrauma. I'm not sure what good it's going to do to wait until Monday, aside from it maybe just being more convenient for myself. So I would take them the next day personally.
Okay. Let's see. I think Dr. Dhall is back. Aaron, can you make Dr. Dhall a co-host, and we'll try to have him share his screen again. Okay, great. So Sanjay, welcome back. We won't make fun of the Wi-Fi at UCSF, but we know it's a great institution, so we'll leave that alone.
It's a great.
I already had some UCSF people upset at me for different reasons. But having said that, so welcome back. Sorry about that.
Yeah.
I was just asking.
You can tell them at least you have good Wi-Fi.
Yeah. All right. So welcome back. Go ahead.
Yeah. Well, let's fingers crossed it stays on, but. So, what I was talking about was timing of surgery, and I kind of caught a few. Can everybody hear me okay, by the way? Okay. So I caught a few comments about timing of surgery. I'm gonna cut to the chase on this. when we looked at this data, I did not honestly expect there to be a major therapeutic benefit to doing surgery at any less than 24 hours. But I was really shocked, in that we found that surgery within 12 hours really, and this graph kind of shows it, I think, that the AIS grade improvement was significantly greater than even people who had surgery within 12 to 24 hours, greater than 1 AIS grade versus less than half in the 12 to 24 hour group. So if you interpret this, really strictly, then what this says is if you're going to wait greater than 12 hours, you might as well wait a few days. The other thing that I think was really compelling was that the conversion rate, which is historically one way that we've looked at outcomes after surgery for spinal cord injury, the AIS conversion to a better grade was dramatically different. It was 89% in the ultra early group versus 29% in the early group, people who had surgery within 24 hours. So again, striking difference. This is an interesting topic, and when I've presented these data at meetings from everyone, we had like meetings, I would get some really interesting feedback from my colleagues. Some would be excited about it, some would say not so nice things to me. And the way I've always looked at it is, in the vast majority of places, spinal cord injuries are not nearly as common as brain injuries. And, those of us who are neurosurgeons, we're already coming in and operating on those. None of us would sit on somebody with a midline shift and a blown pupil. And so, I don't think it's that dramatic of an ask. The other thing is I overheard somebody talking about complete injuries. And, when I present these data at other places, I very often get asked, okay, well, do you do all this stuff in the complete injuries? And, what I'll say about this is if there's one thing I've learned from our own experience is that complete injuries, I really don't know how much the word complete means anymore, especially from a clinical standpoint. And I'm going to show a little bit about that. But, when we see people who have complete injuries, the clinical exam is just one part of it. And I am getting to be of the opinion that probably the least reliable data point in spinal cord injury care is our exam. And what I mean by that is depending on when you see somebody after their injury and what confounding factors you have, right? Language barrier, age, drugs, concomitant injuries. There's so many things that confound our ability to examine these patients. We really just can't rely on the clinical exam. And I think some of the things that we've seen that really help us understand that are electrophysiology, right? And so the really crude analogy I like to use is none of us would ever imagine, if God forbid, you have chest pain, you go to the ER and, somebody puts a stethoscope on your chest and says, oh yeah, you're having a severe heart attack, right? I mean, that would be ridiculous, but that's how we treat spinal cord injury, right? We do a clinical exam and we say, oh, this guy's complete, he's done for, let's operate on him next week. We use laboratory biomarkers, we use electrophysiology, we use imaging, right? And these other disease processes. And we're really just starting to catch up in spinal cord injury. So one example of that is electrophysiology. We set out, when we wrote guidelines in 2013 on spinal cord injury, Mark Hadley, who got me involved in that, he and I wrote a section on intraoperative neuromonitoring for spine trauma cases, and it got rejected. And it was rejected because there wasn't really one iota of literature at the time on the topic. And so I sought out to say, hey, I'm just going to write, a experiential paper on intraoperative neuromonitoring in spinal cord injury. Well, lo and behold, actually, it turned out to be something more than that. When we actually looked at these folks, we noticed that there was a striking difference and there was a dichotomy of patients, especially complete patients, like I was saying before, where there was a big chunk of people that we would take to the OR who were clinically complete, who had no MEPs. And most of those patients did not improve post-operatively. But then there were people who we took to the OR who had no exam, And we got baseline motor evoked potentials, and every single one of those people improved neurologically. And that's what this image on the right is trying to show us, that nobody remained in ASIA A if they had MEPs in the operating room. So
Sanjay,
similarly,
can I ask you about that?
Yeah,
I thought that was really interesting. So if you have a patient right now at San Francisco General who comes in, C6-7 fracture, subluxation, quote unquote complete spinal cord injury, right? No motor exam, no sensation. You're taking that patient to surgery urgently?
Yeah, I mean,
Okay.
we essentially, even though our data is on 12 hours, it's kind of hard to, talk with a straight face to an anesthesiologist and say, well, we have 12 hours, so can I do it? Can I do the case at 7:30 tomorrow morning? So I just do them emergently, each and every one of them. And I think that kind of person is absolutely somebody we would want to do emergently.
Okay.
The ones that I'm still on the fence about are the people with a milder injury, and mainly because, I think I overheard somebody making a comment about, central cord and, I'll do it tomorrow morning. And I do not think that there's anything unreasonable about that. If you've got somebody who's got burning hand syndrome, I don't think you need to whip them off to the OR at 3 a.m. But if I've got somebody with a catastrophic neurologic deficit, I cannot think of a downside, at least at our institution. And again, I'm very spoiled here, except by the Wi-Fi, by
we forgive you.
the resources that we have. Yeah.
But
the Wi-Fi is kind of,
and I'm sorry if you're going to get to this, but I think this is important now, since we have, this is a really nice point. So you have a complete, quote unquote, complete spinal cord injury based on exam. You have a terrible fracture, fracture dislocation, bilateral, let's say jump facet, severe spinal cord injury. You're getting an MRI on all those patients?
We do, and I'll
Okay.
tell you, I do not think that that's necessary. I do it because it's very easy to get. We have a brand new hospital that was built by that Facebook guy, and we have an MRI scanner right next door to the emergency room. And so it's easy and it's safe. When I was at Grady, I never did MRIs on spinal cord injury patients because the MRI scanner was in the basement of the building next door, and every year 1 to 2 trauma patients died in the MRI scanner. Because it was essentially like leaving the hospital, right? So I think it depends on your institution and what you have available to you. I often tell our residents here this, that I don't, generally speaking, I don't think you need an MRI to figure out what's going on in a spinal cord injury patient, unless it's somebody who's got maybe a central cord injury and you can't really tell based off of a CT where they're most stenotic.
But your
but no,
your current algorithms, you get an MRI, you take them back to surgery within 12 hours. And this is the point I want to get to. You're doing monitoring, you're doing MEPs on all of these patients.
Yeah. And again, this is where I'm fortunate that I have that resource available to me, that we have, a really good team for neuromonitoring who's readily available and can get into the operating room. If presented with a scenario where they're not available, would it stop me? No, I would just do it anyways, right? So, but
and I should be better read on your work because obviously it's very important work, but so I apologize if you're going to cover this or it's intuitive. But when you take these patients with complete cervical spinal cord injury, ASIA A, you're doing MEPs. What percentage of those, I mean, I'm sure you know this, it's your data. What percentage of those patients you're actually getting an MEP response before you start the case? Is it a very small number? Is it, hey, a not inconsequential number, or is it a decent number?
I'd say, just off the top of my head, I'd say maybe 30-40% of these people will have MEPs. And what I think it comes down to, Ali, is
that's interesting.
It depends on the timing of the injury and when you get them. And this is where there's variability amongst institutions, right? So, in San Francisco, this is going to sound crazy, but I swear it's true. Our mean time from injury to emergency room is 17 minutes. Okay. Yeah. So, and that's not just spinal cord injury, that's all trauma patients, right? Because we have a very unique, situation where all of our trauma patients are coming from basically San Francisco and northern San Mateo County. So if you think of SFO Airport, that, it's kind of like extending down there. And They all get driven in by ambulance. Our ambulance system is very efficient. We do not have a helipad. So we don't have people who are transferred in from 300-400 miles away, like we did at Grady, for example, and other places. You know, certainly people on this call
I
have that
Thank you
scenario.
for that.
Yeah.
Yeah,
So,
I apologize for interrupting, but I just thought that was a very interesting point. So you do MEPs on all your patients, and and what you're showing here is for those patients who have some MEP response, they actually can have a good, a decent neurologic recovery to some degree.
yeah,
Even if they came in as Asia A under clinical exam,
right.
or Asia A, you are seeing those convert.
Yeah, and where I was going with my very long-winded answer was that if I think there are a lot of people with spinal cord injury who are quote unquote complete the moment they hit the ground, right? But then by the time the ambulance scoops them up, and by the time they go to the local hospital ER, and then by the time they transfer to you, they may have already made some recovery. So you would walk in and just say, "This is not an Asia A. This is an incomplete injury." But if it had happened in San Francisco, I would see that person 17 minutes after their injury, and they'd still be complete clinically. So I think that's that is a confounder that I would openly admit to. But yes, every single patient that we have had that has had MEPs in the operating room has made some degree of neurologic recovery. I haven't yet seen one that didn't get better with MEPs. And I think what that represents is the degree of the injury of those tracts, right? Like a contusion or a concussion to those long tracts versus severing of those tracts. So that's what I mean when I say, I find the complete injury even more urgent or emergent than the milder injury, right? Like, so, I actually take issue with, as much as I love and I utilize the SLIC score and the TLIC score, one thing that I've always taken issue with is that the incomplete injury gets more points than the complete injury, because that reflects some nihilism, which I think is not fair. I think there are, outside of somebody who clearly has a severed spinal cord on imaging, there's still a lot of room for recovery in these folks. One thing I was just going to mention briefly is, talking again about biomarkers, I think imaging is obviously a very important biomarker. We came up with this very simplistic score that we call the BASIS score. We named it after our research organization, where we look at the degree of signal change within the spinal cord. And so intuitively, it makes sense in that the less signal change they have, for example, if it's isolated to the gray matter of the spinal cord, those folks tend to have less severe neurologic exams, and they tend to make more of a recovery. And then it progresses to more signal change within the cord, and then ultimately to hemorrhage within the cord, which tends to correlate with a more severe and permanent neurologic deficit. And then we've done some more exciting work with our neuroradiology colleagues, with some more high-tech imaging. So, again, I think what we're learning is that there's so much else that goes into the diagnosis and prognosis. The other thing is, what do we do with these patients besides surgery, right? So surgery is certainly probably still the most important thing we do, because we're decompressing the cord, either through reduction or direct decompression. But what about post-operative management? And again, I'm old enough to remember a time when there really wasn't any such thing, right? It was, you got in the OR, and then they went to the ward, or maybe they went to the ICU and they kind of hung out. And then, they're well over 20 years ago now, I guess, or sorry, not over 20 years ago, a long time ago. The group at the University of Alabama looked at mean arterial pressure, and they published some pretty compelling results on blood pressure management and spinal cord injury. And they really, I think, helped kick off what has now become a standard of care, using vasopressors to support these patients. And so we've really been focused on trying to initiate this very early. And I think, probably many people have seen this happen, where in the excitement of somebody coming in with a, like Ollie's example of somebody with jump facets and a complete injury, it may not be the first thing that crosses our minds to look at the vital signs and see what's going on with that. But I've certainly seen people who have progressed from incomplete to complete spinal cord injury because they got hypotensive. So it is something that is important. So, I think I was thinking about showing some cases, if that sounds interesting. So let me move forward through there. So here's the first case. This is a 34-year-old emergency medicine physician who was out surfing in Ocean Beach, and he fell. And actually, what happened to him is he wiped out while surfing and woke up face down in the water, couldn't breathe, couldn't move, and was essentially drowning. And of course, being in San Francisco, there happened to be an ICU nurse on the beach, as well as a PM&R spine fellow on the beach, and they both ran out and pulled this guy out of the water, and they resuscitated him. And so, in the field, he couldn't move at all, and he actually had a pulseless cardiac arrest. They brought him back, and then they brought him to the emergency room, and we had this clinical exam where he had 0 out of 5 motor function in his arms and profoundly weak in his legs. Here's his CT scan, and this, it's interesting, I think, mainly because there's not really much going on here. He's got some less than consequential fractures of his spinous processes, and that's about it. When we look at his MRI scan, he's actually got some stenosis here, really at C3, 4, 5, and he's actually got signal change within his cord. And if you look at that signal change, it's isolated to the gray matter of the spinal cord, especially at C3, 4. So, I guess I would throw this out to the group. What do most people like to do with these kinds of scenarios? And what's the management from the group, or comments, or
what do you think, Michael Galgano?
So is this patient in spinal shock? I had actually asked a question in the chat. I'm curious what your thoughts are as to how we determine the accuracy of the ASIA scale if a patient may be in spinal shock, and who we're ultimately relying on to deliver that information to us. Are we relying on our intern or PGY2, chief resident? So I guess that's one question I would pose to you, and then I kind of go into what I think of this.
Yeah, I think that's a really good point, right? If you look at that INSCI worksheet that we use to determine an ASIA grade, if you look at it, I believe it says that you're not really allowed to assign an ASIA grade until 72 hours post-injury, right? So, but who's going to wait around 72 hours to find out? Which really begs the question of how valuable is that outside of just grossly quantifying how weak someone is. Could there be an element of spinal shock? I think certainly there is, right? Because this is somebody who's gone on to become a friend of mine, and when he tells his story, he was most definitely quadriplegic in the water, like no movement in his arms or legs, right? Before he kind of lost consciousness. So without, and by the time he came to the emergency department, he was moving his legs, though he was very weak. So I think you're right. And I think there are a lot of people, like I was saying earlier, who have more of a deficit before they arrive at their tertiary care institution.
Yeah, so for this guy, I think I would see kind of, over his time course in the ED, I'd get him into the ICU, and I'd like to see how he recovers, within the first 10 or 12 hours before I rush him off to surgery, because, I don't see any focal point of stenosis. There's no significant fracture here aside from these SP fractures and whatnot. So I'm not really sure, unless I'm missing something on some of the other axial cuts, that there's really anything truly to decompress in this particular situation.
Well, let's see what Dr. Gibbs, can you hear me? I wanted to see what our neuroradiologist thought about the degree of stenosis, because Michael, I don't disagree with you, but I don't know, is this considered moderate to severe stenosis?
I think the cord is swollen, but I don't know if that there's necessarily stenosis from a disc, a fracture fragment, or flavum or something along those lines. So that begs the question: do we just do a multi-level laminectomy, fixate the guy, and allow his cord to swell, or do we just allow him to cool off over time?
Yeah, good thought. Sanjay, from the audience, Dr. Sharivar wants to know, would you give this patient high dose steroids in the first 12 hours?
No, I wouldn't give anybody steroids. I didn't even include steroids in this talk because I didn't think people were doing it anymore. But I think it's, it's pretty, when I talked about guidelines and I talked about the one RCT, that was the one I was talking about, which was the NASA study looking at steroids. And, it's unfortunately very flawed, and it's quite striking because it got published in the New England Journal of Medicine, though it was over 20 years ago. They threw out over 60% of their patients before they did the analysis. So it was kind of a fatal flaw. And there's been so many studies that have shown morbidity of steroids and spinal cord injury. I feel like we're more likely to hurt him, even a young guy like this, than help him. Who's still doing it? Anybody?
I still do them for cervical fractures in patients that are, I don't really have a strict black and white cutoff, but I would say if they're less than 35 years old, they're relatively healthy, they have no major medical comorbidities. Yeah, I'm considering doing it in cervical spine. Thoracic, absolutely not. No.
I see.
Sanjay, another question from the audience. A question, I think you alluded to that very quickly, which was biomarkers. Any role, any really proven effectiveness of biomarkers to determine or to make decisions regarding emergency surgery or not, especially in the unconscious or unresponsive patient?
Yeah, and I'll tell you that is a fantastic question and very timely. I'm fortunate enough to work with some scientists, one in particular, who has been really focused on identifying blood and CSF biomarkers, and he's made a lot of progress on this. It's not ready for prime time. It's probably not coming to a hospital near you anytime soon, but I think it will, and I think it will serve as a valuable test, again, for quantifying severity of injury, so we can get to a point where, will it influence surgical decision? I don't know, but I think at the very least it might provide itself as a prognostic tool and also as a diagnostic tool, right? There's many scenarios both in the civilian and in the military world where it's not totally clear whether somebody has a spinal cord injury, and so we're hopeful that it'll be helpful in those scenarios as well.
Great, thank you. So I'm curious to know what you did for him, because the two things in my mind were, do you admit him to the ICU and push up his maps, or do you take him straight to surgery? I'm curious to see what you did.
Yeah, so he actually ended up in the operating room about 3 hours after his injury, and he got operated on by one of my partners actually, and he got this multi-level posterior decompression and fusion. I think the comments, about spinal cord swelling are spot on, right? I mean, I also feel like, especially in somebody like this who's a young, healthy guy, that is what we were dealing with. That said, I don't think it's wrong to consider decompression. And again, I would, allude back to brain injury, right? We routinely decompress injured brains, right? We don't give much thought to the fact that the brain, that there wasn't pressure on the brain because it was swollen before the injury, right? So it still is, I think, very valuable to recovery in somebody like that. It's an interesting question about whether or not you maybe put the guy in the ICU first and watch him. Again, even though I wouldn't critique someone for doing that. I think it doesn't hurt, especially a guy like this, to just whip him off and get him decompressed, right? If you've got somebody who has another reason why it's going to be hard to operate on them, whether it's another life-threatening injury or somebody who's so old and so frail that you're worried they're not going to make it, then certainly sometimes it makes sense to pause and think it through.
So Sanjay, for this patient, so for this patient at San Francisco General, post-op, okay, fine, you made the decision, he went to surgery. Will he still be admitted to the ICU for MAP pushes above 90 for a total of 7 days?
Yeah, so we actually do 85, a map of 85, and we do 5 days. And I'll be really honest with you, Ollie, it's totally arbitrary. Why 5 days? Because that's how everyone's always done it, right? And that's what we've studied. Is that too much for some people? I think so. We often have this conversation whenever we have somebody with a central cord injury and they're doing great. They've got like maybe some hand weakness, and they're, just last week I had a guy, who had a central cord with very mild hand weakness and significant cardiac disease. And I shut off his vasopressors at 3 days. Why? Because I just thought it's such a great prognosis for recovery. I was more worried that I was going to hurt him with the pressors. But in him, yeah, he got 5 days. And actually, interestingly, he didn't get MAP goals. He was actually the very first patient to be put on a new protocol that we have, looking specifically at spinal cord perfusion pressure rather than MAP goals. And this emanated from the Camper trial, which was run by Brian Kwan out of University of British Columbia, looking at intrathecal pressures through a lumbar drain and then calculating a spinal cord perfusion pressure by subtracting that ITP from the MAP. And what was really interesting in the results from that study was that there was a very direct relationship between SCPP and the relative risk of neurologic recovery, i.e. relative risk of a good outcome. And that was not seen with MAP goals. And also, I don't have a graph showing this on this slide deck, but there was a titratable benefit between SCPP, spinal cord perfusion pressure, and the degree of neurologic recovery that plateaued around 60 to 65 millimeters of mercury. So what we decided here at UCSF was, based on that, we were going to implement this as our clinical standard of care in all of our severe cord injuries. So he got this kind of setup where he got a lumbar CSF drain. At this time, we're not draining, but we're about to launch a trial where we're going to look at drainage specifically. And we use that to get an SCPP, so kind of a corollary to TBI. And we do that for 5 days. So he was the first patient to get that. And he went, and yeah, I didn't show an outcome, but he went on to make a full neurologic recovery. And he's doing great. He actually retired from medicine and he's a professional artist now. So I've got another case if you want to talk about it.
Yeah, please do. This is our favorite part of the discussions, usually are the cases. So
yeah, for sure. So this one, we're going to change gears here. Okay, so this is a 39-year-old woman, who was brought in by ambulance, motor vehicle accident. Kind of an interesting story. She drove into a parked car and the airbag deployed, and she fully remembers the entire injury. And she said what happened was that the airbag caught her between her right shoulder and her head and cranked her head all the way over to the left. And she came into us with pretty profound weakness in both arms. And so, here's her CT scan. Here's a midline cut. You can already see that spondy at C5-6. Interestingly, so this is the left-sided facet joint at C5-6 that's fractured, dislocated, and on the right it looks pretty good. And I'll show you the here's some more cuts of it, and here's the MRI. And again, she's kind of got this cord signal change that's isolated to the gray matter of the spinal cord, but no real stenosis or compression. But she's very weak in her arms, almost completely out in her arms. And I apologize, on my slide before, I think it had right and left reverse. Her right arm's actually weaker than her left, which is interesting because the facet fracture was on the left, the dislocation. So what do y'all want to do in these scenarios? This one's a little bit weirder.
Well, knowing you well enough, I know you like to go posterior, but we're going to ask what our colleagues here think, because there are we put a lot of these cases online, and a lot of people really love the ACDFs for these plus or minus posterior. But let's see, Alex, let's see what the European perspective is. Alex, what do you think of a case like this? Are you an ACDF surgeon for this, or do you think it's too unstable and you need a back front from back?
This is difficult. Yes, this is a great case 1 and 2. We can discuss hours. What is spinal instability? Is this instability with a obvious, with a listhesis, with a facet fracture, is this more unstable, or is case 1 more unstable, where we have seen a lot of strains in the ligaments? We have seen the same amount of hematoma in the anterior. I think I would do it here, anterior ACDF with a crest and a plate, and I will do it from posterior as well. I've seen too many patients going to kyphosis because the amount of the posterior injury, I think we always underestimate it. Maybe it's bigger than it is. I would do it anterior and posterior with laminectomy as well and fusion.
Yeah, I, you know, as Ollie pointed out, you know, I've had plenty of failures to reduce, especially like jumped or locked facets through an anterior approach. You know, knock on wood, I haven't yet failed to reduce through a posterior approach. I've essentially abandoned, you know, traction and all these maneuvers, and I just basically do the same thing every time. You know, just prone them and drill off the facet joints, and they all reduce, and that seems to work. One question for Ollie, you know, as you mentioned ACDF, when you've got somebody with this facet fracture dislocation and arm weakness, and certainly, you know, you could rack it up to central cord, but do you feel like that ACDF is enough to decompress that neural foramen with that, you know, with that fractured up facet joint? Does that influence your thinking?
Sanjay, that's a really good question. And in full disclosure, I also like the posterior approach because you're right. You can always reduce them. You can get a direct decompression. It's, you know, it's just easy for us. But I have done a few ACDFs for this, and you know, you're not going to be able to get that nice decompression off that nerve root. Now, if you want to say that injury is due to neuropraxia or due to the initial insult, and even if you decompress, they're not going to get better. I know some people say that, but if there's a significant fracture in the foramen and the patient is having an acute radiculopathy, I think they deserve a direct decompression posteriorly. If it's one of these facet fractured, you know, kind of perched facet, I have no problem doing it from the front and watching them. So that's a long way of saying, you know, I don't know. I think it depends on the case, but you can never go wrong with a posterior direct decompression and multi-level fusion like you did here, albeit probably at the level of 1 or 2 more motion segments than if you were to go anterior. But there's a lot of people, especially on our orthopedic colleagues, who love to do these, you know, and successfully do these with an anterior approach alone.
Yeah, I mean, the other thing that's happened to me, and maybe it's a reflection on me, is I've seen people rip those plates out, you know, and I think it kind of depends on how unstable their injury is. So this is what we ended up doing. You know, we did this multi-level posterior construct and you know, direct foraminotomy, or really a facetectomy for decompression of the nerve root. You know, what's really interesting again is that the facet injury was on the left. The patient, even pre-op, it struck me that when I examined her, she was 0 out of 5 in her right bicep. In particular, like her hands were coming back, but that right bicep did not fire at all. And post-op, she had persistent weakness in that right bicep. So here's a little interesting neuroradiology finding, is if you look, first of all, there's a lot of edema in the scalene muscles. The other thing that we saw was there's actually blood at the dorsal root entry zone on the right-hand side. See, this baffled us for a while because we were trying to understand why she had the C5-6 facet fracture dislocation on the left, but the right bicep was completely out. But what it seemed like actually happened was she had a stretch injury and an avulsion of the nerve root here on the right side. Again, we think what happened is that the airbag pushed her head all the way over to the left and crunched her down and fractured that facet and stretched the nerve on the right. So kind of a unique injury. I certainly haven't seen something like that before, you know, and again, here's another view of it here. So it's, you know, it was quite striking. So I thought that that was a really interesting finding. So what we're going to do for her is we've actually got one of our peripheral nerve surgeons here who's going to get her an EMG if she's not better in a couple of weeks, and potentially do a nerve transfer for her. So it's an interesting case of somebody who's got both a spinal cord injury and a peripheral nerve injury.
That definitely is a good case, and I agree with you. I think we often, especially in acute cases, focus on the spine, rightly so. But a lot of times, especially motorcycle accidents, bike accidents, the instinct is to hold on, to grab that handle, and stretch injuries. Brachial plexus injuries are really not uncommon, and I actually think a lot of those injuries are due to that rather than potentially the radiculopathy or the fracture in the facet type of thing. So that's interesting. All right, so we got 2 minutes. Let's see this last case.
All right, so here's the next one. So this is a 19-year-old morbidly obese pregnant woman who was in a car accident, and she can't, I'll just cut to the chase, neurologically intact, so a little bit different. And she had this hangman's fracture. So actually, to be totally truthful, my partner took her to the OR to do an anterior reduction, really trying to, not in this 19-year-old woman, not take away C1, C1-2, and could not get it to reduce. So I have a video that's not very long. So
Sanjay, so this is a hangman's type 3. Like, is it a dislocation or just a subluxation? Was it like the perch facet 1?
It was here. I've got an image right here. This is what it looked like when I got there. So my partner had gotten an exposure done, a really tough exposure at C2-3, and this very, very obese patient. But as you can see, it was very angulated, so it was a very high grade hangman's fracture with complete disruption of the disc.
Yeah.
And it was, and so what we did really was, my partner who did this, was struggling to get this reduced, and so I came in, and what we did was, we really packed a lot of towel rolls and anything we get our hands on underneath the shoulders, and really extended her neck. And that was really the maneuver that got this reduced. It wasn't, anything we did in the wound. And you can see here the difference that we got to just by doing that maneuver. And then from there, let's see. So then we just did the discectomy. And I don't know if Coy's on the line, but this is a peak cage, and I thought I would trigger him with this. I'm
texting him right now. I'm telling him you used a peak cage.
Tell him I used peak. I honestly, it was what was available, at that moment. But basically, and then we did more of a direct reduction through that, and got that cage in, and then. And then of course, honestly, putting a plate on a C2-3 is always a humbling experience. And so once we got that reduced, we were able to sneak a plate up in there. And I'm cutting through the video because I know we're running out of time,
but was this, Sanjay, not to get ahead, but was this a staged procedure and you're going to back it up, or did you guys feel like you could do this just anteriorly?
So that's a great point, right? So this woman's 19 and pregnant. I think she was 25 weeks or so pregnant. So we didn't really want to back it up, at least not now. And our initial thought was, we actually got a really good fixation here anteriorly. So we were going to give her till she at least completed the pregnancy and then see how it does. I'd prefer not to back it up, because I think the whole point, well, one was I think nobody really wanted to prone the pregnant woman. But the other thing is, if we go anterior, this is the weird nuance about hangman's fractures, right? If you go anterior, you can go C2-3 and spare the C1-2 rotation. If you go posterior, to my knowledge, the only way to really do this is to go up to C1. And so then you lose that C1-2 rotation. So the thought is that hopefully this will be sufficient for and it was pretty robust fixation.
That's Yeah, that's a really tough case. That plate looks great. You're right. Plating is really hard at C2, and you're right. Posteriorly, I mean, some will try the osteosynthesis and put the screws through the pars fractures, but that's really hard.
Yeah, and maybe, maybe with navigation, and if it's not very angulated or
Right.
displaced, it might work. But then it would beg the question of why does it need surgery, right? So if it's,
There you go.
yeah.
Well, that's one heck of a case to end on. Listen, I'm sorry to cut you through your talk short, and sorry for the technical issues earlier, but we are on time here. Sanjay, thank you so much for running through those cases, and honestly, your phenomenal knowledge of spinal cord injury and trauma. We'll definitely have you back again because this is such an important topic. Everybody loves cervical spine trauma and spinal cord injury, and I'm sure we can go through a lot of cases. And really, it's nice for us to learn, like from centers, from centers like your center, what you guys do, what your algorithm is, and what your outcomes are. So I appreciate it. On behalf of everyone, we thank the participants, the faculty. Dr. Dhall, you're in charge next week. What do you have in store for us?
So next week we will be hosting Dr. Stefanos Volyoun. He's the director of spine at the Ohio State University Department of Neurosurgery, and he'll be speaking about a case-based discussion on management of patients, surgical management of patients with ankylosing spondylitis. Okay, great. So next week, Ank Spondy. Hopefully he'll talk about some trauma cases. The most feared phone call is an Ank Spondy fracture, right? Thoracolumbar fracture in an intact patient. We'll keep that for next week. Sanjay, thanks again. Thanks everyone. And
thank you.
Be safe.
Thanks for having me.
We'll see you next Thursday.
Okay. Thank you.
Take care, everyone.